The title of my talk is New Approaches to Antiretroviral Therapy in Pregnancy, and I'll take it from maybe a clinical perspective and a French perspective, as Carlos said. So how do you move forward? I don't have much to declare in terms of drug companies. There's a big paradigm shift that I think all of you are very much aware of. We're in the era of a universal lifelong ART in HIV-infected women. And basically PMTCT, which was a concept that specifically would use something to prevent transmission from mother to child, is totally now driven by TASP, and women who are on long-term therapy potentially don't transmit the virus to the baby. So one of the major issues which is emerging, of course, is the issue of HIV exposed and uninfected children, and the potential toxicity issues for mothers and for infants associated with the drugs that we're giving to pregnant women. And therefore, I'd say there's a sort of 180-degree turn to make from the past, which was PMTCT, to the present, which is using long-term TASP, to the future, which would be to say, can we have specific antiretroviral strategies designed and targeted at pregnant women, and just not use what we're using in other people who are not pregnant without consideration for the risks and the specific issues of pregnancy. So, as we all know, you can look at data from various countries. As in the French perinatal cohort, you can see that mother-child transmission of HIV has virtually disappeared. In the last few years, it's 3 per 1,000, and I don't know if there's any pointer, but the colored bars just show the increase over the last couple of decades of combination antiretroviral therapies of all sorts, but basically boosted PIs associated with 2 nucleosides. And practically all women are treated, providing the HIV infection is known, of course. And 96% of our patients have an undetectable viral load at the time of delivery. And that's something which can be achieved. And if you look at the perspective of zero transmission, it means that you have to be able to treat women so that they have an undetectable viral load through pregnancy, and the earlier the better. And that's been shown in our cohort on 3,000 mother-infant pairs, zero transmission if therapy is started before pregnancy, continued all through pregnancy, and is successful with an undetectable viral load. And of course, that means careful monitoring, follow-up, and support of our patients throughout their pregnancy and throughout their lives, of course. So the issue of potential toxicities for all these HIV-infected, uninfected, exposed infants is a topic of long-standing research, and also, we have to say, some controversy. And I think to make things perfectly clear, there shouldn't be sort of a dichotomous way of looking at things and saying that drugs have to be all good or all bad. Of course, any effective drug can have some side effects. The question is, which ones would have the most favorable toxicity profile, of course. And the data that we have out there is mostly data on the older antiretroviral drugs, which have been around for several years. And the issues that can be raised are, first of all, malformations. Of course, the first thing that anybody thinks about when you're giving a drug to a pregnant woman is, can it increase the risk of congenital malformations or any type of birth defect? And the answer is basically no, none of the drugs significantly increase the overall risk of birth defects, at least the drugs that have been used in the past. And the only major issue was the issue with Adherence, which is not completely over because there's probably some increase in CNS malformations with first trimester Adherence exposure, but it's a very small increase, if at all. There are other issues which are hematological toxicities in the newborn, but also even later in the child, which have been well documented, mostly with AZT. There's the issue of mitochondrial disease, which French pediatricians were the first to raise in the 1990s, which has been shown also in animal models replicating human data, and mostly associated with zidovudine and zidovudine 3-TC. There are other issues which are emerging or which have been discussed, which are the issue of myocardial dysfunction, basically less good heart contractions in infants exposed to AZT and 3-TC in utero. Although that's also a topic of controversy, and it's very complex to study these ultrasound and cardiac ultrasound in babies. The issue of reduced bone density with tenofovir exposure, with conflicting data from the same studies and basically less alarming data today. The issue of cancer, and there is an increase in cancer, and especially brain cancer, associated with DDI exposure, which has been shown in the French cohort. And this very difficult issue of genotoxicity, meaning that DNA can be altered and there's mutations in cord blood associated with exposure mostly to AZT, but also to some extent to tenofovir, which have been shown in a lab setting. And we don't really know what the exact impact of that will be on the long term for these exposed babies, because of course all of these nucleoside analogues do interact with DNA, human DNA. And most of the data regards nucleosides. The other side of the question is adverse pregnancy outcomes. And this issue has been getting more attention recently. And basically what we all expected was that since poor outcomes, pregnancy outcomes can be related to some of the context of HIV-infected women, and also to HIV infection itself, immune deficiency, but also there's a very interesting studies showing that inflammation, chronic inflammation, maybe microbial translocation could have a role in some of the adverse pregnancy outcomes. And we basically expect that if you treat the mom and improve her HIV status, you'd have better pregnancy outcomes. And that's not really what we've been seeing in observational studies. We actually see that adverse outcomes are abnormally frequent in HIV-positive women treated with antiretroviral therapy, mostly preterm birth. And it's something, I said we were a little bit in a denial state. In my country, 15% of HIV-exposed babies are born preterm, which is more than twice the normal rate in France. And that's something which we started realizing relatively recently, and that's emerged in data throughout the world. And there's conflicting data for some other major outcomes, such as small for gestational age or other adverse pregnancy outcomes in stillbirth and so forth. But there is an issue which is pretty complex in terms of these adverse outcomes. A very large-scale study from databases in the United States, which was recently published, showed this is over 7 million births and 2,000 HIV-positive women. Of course, they're not comparable in all ways between the HIV-positive and the controls, but there is an increase in some of the adverse events, and especially preterm delivery, also intrauterine growth restriction, and also maternal death. So you can see that there are various types of evidence which converge to show that exposure to these antiretroviral therapies can increase some of the adverse outcomes. And the problem is we don't know why. It's a very puzzling issue. And there are hypotheses. First of all, is it just confounders, other factors that are not related to either HIV or the therapy? Or is it related to antiretroviral therapy? Is it immune restoration? Is it individual antiretrovirals? What's the role of the PI boost, which was a topic of study in our cohort? The modified inflammatory response in pregnant women on antiretroviral therapy. Also issues with just pregnancy complications, which would lead to medically induced preterm birth and not spontaneous preterm birth. And there's a whole area, a very interesting area of study regarding steroids and reduced progesterone in particular, which some groups have been working on for a few years, and there are actually even clinical trials that are underway to supplement in progesterone and try to reduce some of this toxicity. Now, all of this was in observational studies, and sort of a bombshell was the impact results from PROMISE a year ago, where there was a comparison between PMTCT, classical PMTCT, and triple therapies, and these were showed that triple therapy did better in terms of mother-to-child transmission, but in a randomized clinical trial, there was actually an increase in perinatal deaths, adverse maternal outcomes, and preterm births in the tenofovir-based antiretroviral therapy versus zidovudine-based antiretroviral therapy, leading to basically a counterintuitive idea that tenofovir could do, instead of doing better as we expected, maybe do even worse in terms of perinatal outcomes. And this is something really we have to be quite concerned about. So what to do? We have a large number of options to treat pregnant women, and this is, of course, in European countries, but also more and more throughout the world, and planners will have to make decisions about what drugs to use. There are the older ones that we know about, there are more recent ones that we know less about, and there's, of course, the issue of single tablet regimens, which are pretty popular and have advantages, but also are basically mostly drugs with less data. And the issues of what to use in practice today is that basically the issues are the same for most of regarding efficacy, resistance, adherence, cost, and there's no evidence at all anywhere that would say that such and such a drug would do better in terms of preventing mother-to-child transmission. As long as you get the viral load down, it'll work as well. But there's unique pharmacokinetic issues related to pregnancy, and of course unique safety issues which are related to pregnancy and which have to be addressed specifically in pregnant women. And this paradox is that we're using basically older antiretrovirals because we know more about them. We know their good and bad aspects, and it's sort of difficult to move forward to the most recent ones, which we have little data about. And in usual guidelines, I'll just say a word about the French practice today and French guidelines, which have just been updated very recently. And basically, there's very little change. The change is kind of slow. And when you look at the data, it's hard to say, let's just do completely differently from what we did a few years ago. And basically, we're recommending first, as a first line, boosted PI and 2 nucleosides. And the only thing is that the boosted PI today is usually darunavir for tolerance issues rather than the older ones. But there's good data on all of these. And there's second-line possibilities with efavirenz or raltegravir. The difficulty is if you have a patient who's already on therapy, is it better just to continue her therapy even if you don't know and just kind of close your eyes and say, we'll hope everything will be okay, or to switch therapy with the risk of having less good adherence and getting women confused because they're changing their therapy because of pregnancy. And that's a difficult issue today, of course. There are late presenters. You need specific guidelines. There's no way that you can have one way to treat every pregnant woman. There are always special cases that require multidisciplinary discussion. And there's also the issue of neonatal prophylaxis, which has changed. And nobody's really ready to completely do away with neonatal prophylaxis. But that can also have an impact on the tolerance in the long run for HIV-exposed and uninfected children. So we're using AZT or nevirapine, short-course nevirapine, as neonatal prophylaxis, and of course reinforcing, intensifying prophylaxis in high-risk cases. But for women who have undetectable viral load all through pregnancy, the issue will be, can we downsize the neonatal prophylaxis? And of course, this is not, the guidelines are based on the same data all throughout the world, but not necessarily the same guidelines. And as you know, WHO has recommended for several years efavirenz rather than PI-based antiretroviral therapy in pregnancy. That may be changing in the future. And the US guidelines clearly recommend continuing whatever the woman is taking before pregnancy without regard for the potential side effects specifically associated with the newer regimens. So these are very difficult issues for today. And as you saw in the previous slides, one of the main points which we have to raise is the issue of nucleoside analogues and their specific toxicities. And it's a class toxicity. So of course we don't use DDI or D4T anymore, but there are three options which are bacavir, tenofovir, and zidovudine. And like I said, we kind of expected zidovudine to disappear, but there are also issues with tenofovir, and bacavir seems better tolerated, but there could be also problems with all of these nucleosides. And using a two-nucleoside backbone is something which we really would like to do away with. And we'll go into some of the potential perspectives. So what could we use for better safety? First of all, we have to go back to the data from people who are not pregnant and look into what are the possibilities for treatment simplification. And some of them are just not relevant for pregnancy, such as intermittent therapy, taking it for 4 or 5 days a week, or deboosting, or lower doses. In view of the pharmacology in pregnancy, which is usually lower circulating antiretroviral levels in the third trimester, these are just not reasonable options today. But possibly we could be looking into drug-sparing regimens for pregnant women. And if you want to use drug-sparing regimens, the issue would be, first of all, of course, to maintain the efficacy, first and foremost, and also to think about what do you want to avoid. Do you want to avoid nucleosides? Do you want to avoid PIs? Do you want to avoid both of them? And there are not that many possibilities, but there are several interesting perspectives, and there's a lot of emerging data. And the data is in non-pregnant women mostly. So first of all, you can look at this table, which is sort of a synthesis of the different possibilities I think we should look into, which is first of all nucleoside-sparing regimens. And in non-pregnant patients, we can have nucleoside-sparing regimens with one nucleoside instead of two, using 3TC. And up to now, PIs, boosted PIs with 3TC are an option. And there are new studies that are going to be presented at the IAS next week on PIs with darunavir, which has not been studied much but which is now under study in some trials. There's also the possibility of monotherapy with boosted darunavir, and there are new possibilities with darunavir, dolutegravir, with darunavir plus raltegravir, darunavir plus rilpivirine, and these are there are different studies that are underway, and some of these will be presented even in the meeting next week. And when you look onto the right column in pregnancy data, there's actually very little data available, and I'll tell you a word about the clinical trial which we're performing right now in France for monotherapy with boosted darunavir. Now, if you want to get rid of PIs instead of nucleosides, there are several possibilities, of course, is to use what's been used by the WHO recommendations for several years, which is nucleosides with efavirenz, but then you have the two nucleosides, which is still a problem. There's also now new data coming out for rilpivirine instead of efavirenz. And there's, of course, the integrase inhibitors, which are very exciting, and many data outside of pregnancy, and emerging data in pregnancy, and even some clinical trials, which we'll be hearing about in a few minutes, in fact, from Claire Thorne and other studies which are going to be presented at the IAS meeting this week. And finally, if you want to do away with both the PIs and the nucleosides, there aren't that many options possible today, but using, say, for example, dolutegravir and rilpivirine could be an option, which is under study today. There's a SWORD 1 and 2 study which is underway. There's absolutely no data, however, in pregnant women. So like I said, there was emerging data about riltegravir, and in the literature observational studies, we're looking into the data from the French cohort, which is over 400 exposed pregnancies, but it's just observational data and it hasn't been published yet. And there are two randomized clinical trials, one that are underway. I don't think that any of the results are available yet, one of which is sponsored by NICHD, and there's also other studies in Brazil. And the issue with dolutegravir, which is a very exciting perspective, and so Clara will be presenting some data in a few minutes. And there have been several preliminary publications, and actually a couple of clinical trials which are underway, and 3 papers which are going to be presented next week at the IAS meeting, which we're really looking forward to, especially the one in Botswana, which is nationwide birth outcomes, which will be presented on Monday or Tuesday. So the last issue, as I mentioned, is using boosted PI monotherapy, which is one of the only ways today that has been validated outside of pregnancy to control viral load. And we have data in pregnancy from one study which was performed in the French cohort and published in CID, which is the Primeva study. And this was at the time for women who were not on therapy and who had relatively low viral loads and safety profiles, who were offered a randomization between monotherapy and traditional triple therapy with 2 nucleosides. The results were relatively interesting, especially they were extremely effective in women with low baseline viral loads. But this approach is not something we really want to promote, because we're promoting long-term antiretroviral therapy starting before pregnancy. And this is what we're looking into now. And the idea is moving women who are on triple therapy and with perfect control of their viral load, long-term viral load control, to darunavir-boosted monotherapy during pregnancy. And this is the ANRS 168 study, which I'll just say a couple of words about very rapidly. The study treatments in the mom, the idea is to completely avoid all nucleoside exposure for the baby. And we're giving darunavir to the mom, boosted darunavir, and no AZT at delivery or in the baby. And it's nevirapine for 2 weeks, which is something which is commonly used in French recommendations today. Of course, viral load will be monitored monthly, and any woman who increases her viral load will be switched back into intensified therapy with adding back nucleosides. And the outcome which we're looking into, this is a pilot study, an open-label, one-arm pilot study, which is just to see what is the success rate defined as maintaining an undetectable viral load throughout pregnancy with this darunavir-boosted monotherapy. And of course, we'll be looking into the toxicity issues also. And this is a very selected population. I'm not going to go into all the eligibility criteria. We're going to start that. We start it as early as possible in pregnancy, and only in women with viral success and no evidence of high reservoir before pregnancy. And the study hypothesis is that we'll have an over 90% success rate, and the estimated number of patients to enroll is 120, and we're almost halfway there. With 35 centers in France, and I hope we'll be able to at least show that this monotherapy can maintain a low plasma viral load. And this is just meant to be a proof of concept, because today this is a hypothesis, but we need to really be able to say that we can optimize antiretroviral therapy in pregnant women without using nucleosides at all. And this doesn't mean that we'll solve all the issues. First of all, there'll be the issue of PIs. We're just doing away with the nucleosides, and the next step might be getting away with getting rid of the PIs. And also the issue is, can this type of approach be used throughout the world in places where viral load monitoring is clearly not available. We have patients that will come into the clinic every month. We'll get their viral load results within a few days. And of course, if anything goes wrong, we can intensify the therapy. And that's not something you can do that easily in a lot of places in the world. So we need to be very careful about the risk of viral escape, of resistance and the genetic barrier and so forth. So in conclusion, I'd say the road to eliminating mother-to-child transmission, that's the quote-unquote easy part, although we all know how difficult it is. The most difficult part is eliminating this transmission with minimal toxicities, which means that we have to have a very ambitious research agenda, not only observational, but we really need that observational data from all our cohorts, which is follow-up of maternal and fetal outcomes with all of the new antiretroviral drugs. There's also a real need for clinical trials in pregnant women. And I think that we're all probably in this room, we're all convinced that research in pregnancy, we're talking about children as orphan drugs in children, but pregnancy is a field of orphan drugs. It's very difficult to conduct research because there's just a thing about conflict of interest, but the drug companies, they really hate the idea of testing any drug in pregnant women, because they consider that out of the, say, the worst adverse events that you can imagine in a person who's on antiretroviral therapy is number 1, dying, number 2, serious hospitalization, and number 3, becoming pregnant. That's considered in the guidelines for antiretroviral, for any drug development today, it's considered to be a severe adverse event. Pregnancy is a severe adverse event. That's something really which I'm quite shocked about, and I think we need to move forward and say that pregnancy is a wonderful event, and what we want is to be able to have drugs that will be most useful in our patients. And maybe in the future, what we want is 100% effective on viral load, but absolutely no mother-to-child transfer of the drug and exposure to the baby. So thank you for your attention. I really would like to thank all our collaborators in the French perinatal cohort team, many of whom are here today, and thanks for your attention.